Did you know that the bacteria in your mouth can actually cause heart disease? Join me as I talk to Dr. Tom Nabors, who's been researching the subject for over 40 years, about the impact of oral pathogens on systemic inflammation, heart disease, and cancer on this week's episode of Hunger Hunt Feast. Thank you for joining me today for another episode of Hunger Hunt Feast. With me is Dr. Tom Nabors. Tom, welcome. Thank you for joining me today, Tom.
Thank you, Dave.
Dr. Nabors was the first to start. Well, you were a founder of Oral DNA Lab, so you were early, if not the first, I believe, to start testing for the for both oral pathogens and genetics, and their role in not just oral disease, but in systemic disease, how they affect it, specifically heart disease. That's correct?
Yes, that's correct.
Yeah. So, I mean, that was, so you had your own lab. You founded this Oral DNA Labs. When was that? How long ago was that?
Well, Oral DNA was actually founded in 2008. Prior to Oral DNA, I had a business relationship with a German company beginning in 2003. So actually in my practice, I was using a German DNA PCR laboratory because they were the only one in the world that was actually doing what I wanted them to do. And we had no laboratory in the US that was actually doing that. So I was sending samples to Germany in order to get the result reports. The information was so compelling for me that I wanted to bring the German laboratory over here. They had a very nice track record throughout Europe. And unfortunately, they decided that going through the CLIA and CAP or FDA, whatever is appropriate for making sure that these laboratories are validated, in other words, have accurate information, they declined to go through that very lengthy and costly process. So in 2007, I was approached by some businessmen that had seen what I was doing and said, would you be willing to build a lab? And so I said, of course, we need one here. So that's sort of a very short history of getting to Oral DNA Labs, which we launched in 2008. One thing unique about our laboratory is we were the first to use saliva as the only analyte. We were not using any blood at all. And so we're all familiar with saliva now as because of COVID. Everybody's using saliva now because of COVID. But just sort of briefly, I had become very interested in the role of saliva, not only in protecting the mouth, but also in its function as the beginning of digestion. But more importantly than that, in my opinion, was what are these microorganisms doing? Bacteria, viruses, fungi. What part and what role do they play in not only in the health of the mouth, but is it possible that they actually contribute to, let's say, cardiovascular disease, or let's say the general term systemic inflammation? And that's kind of where that beginning occurred.
Wow. That was revolutionary, that to connect the bacteria of the mouth to the whole body. So, and you could tell this by looking probably often at the health of the gums.
Well, interesting enough, in oral health, and we would call it hormone medicine, while we do many different things, right? Related to teeth. Of course, we're looking for oral cancer, and we're looking at whether the salivary glands are working properly. We're looking at muscles. We're looking at TMJ. We're looking at a lot of things that affect normal function and keep people happy relative to their normal daily activities. And so what I observed, even going back in the early 80s, is that our treatment model was so inconsistent. And that's really what drove me, Zane, into leaving clinical practice and developing a laboratory, is because I was very concerned of the inconsistency in the treatment models that we were offering for our patients. And we were actually telling patients that periodontal disease is a non-curable disease. That just kind of sets up a lot of red flags in my mind, And so I said,
Right.
you know, is that really true? Or is it something that we're missing? And so really over the last 40 years, what I realized what we're missing is the ability to determine the differences between clinical health and clinical disease, because we were only using the clinical signs. So you were asking the question, is that what you see? Well, yes, we can see disease, but is that what we want to do? Do we want to wait till disease actually occurs before we actually make a person aware or help them become aware that the disease is imminent? It'd be like saying, well, let's wait till you have a heart attack and then we know you have cardiovascular disease.
Ah, gotcha. Gotcha. Okay.
Yes.
So you were trying to get on the front end of it. Well, I mean, you've been teaching on this for over 40 years.
I have.
Is that
Yeah.
correct? So, I
Yeah.
mean, even before the labs in 2003, you were zeroing in on this
I was.
really early on.
Yes. Well, I was one of the first two to begin to use phase contrast spectroscopy prior to our ability to use DNA. I was using a research laboratory in my clinical practice looking at this biofilm that we call plaque. And we were actually recording what we were seeing at high power and what we were observing. And by the way, I didn't invent that in any way. I learned that from a colleague working at National Institute of Health. That's what they were doing in research back in the late 70s and early 80s. And what I realized is that the microflora of a healthy mouth is very different than the microflora of a diseased mouth. And when we look at that under a high-powered microscope, we can see that. We can also see a lot of the immune response to the types of bacteria that we see. As an example, we can see white blood cells, and we can see macrophages and so forth. And so that gives us a window in, even early, prior to DNA, we could look at what we call morphotypes, making a clear distinction between what a healthy microflora look like and a diseased microflora look like. And so we began to record these cases early on using videotaping, and then we would record after treatment to see if under a microscope it changed significantly. And then we also began to use certain antiseptics that were not being used at that time in order to help us resolve the infection. In fact, my goal has always been to cure the infection, to resist the idea that this is an incurable disease. And what we showed very clearly is that we could cure these diseases, particularly if we caught them early. And I began to take photographs. I began to use my microscope studies, and I began to present cases to my friends and clinicians, and I was being invited to different states to show what we were doing. And by the way, I didn't invent any of this. It's just reading the literature and applying. And I would say that my greatest contribution to my patients was actually reading literature, finding stuff that people were not using, but that was validated, but then actually applying that information to patient care.
Wow. And so you applied it beyond just oral disease, but you really started showing risk of, like you said, systemic inflammation.
Yes.
So by treating the mouth, you found that you were able to reduce systemic inflammation?
Yes. And that's a pretty long story too. I'll make it as short as I can. The first study that really came out relative to the potential relationship between cardiovascular disease and the health of the mouth occurred in 1989. And the observation was that individuals that have periodontal disease, in other words, an infection in the tissues of the mouth, actually have a higher incident of heart attacks and strokes. And so at that point in time, they were trying to determine, is this coincidental? In other words, do these individuals have same, let's say, habits? Do they also, cardiovascular, do people smoke? Well, if they have dental disease, do they smoke? And so they were not ruling out the traditional risk factors that are associated with, let's say, cardiovascular disease. And they could not answer that question. Is this just an accident, or is it really a causative relationship? So really, since 1989, that's where tens of millions of dollars have been spent in looking at these relationships and trying to figure it out. And ultimately, many of our researchers in the medical field of all types, from cardiology to diabetes, to arthritis, to mental health, have all been looking at this potential relationship. And back around 2005, as we followed the literature up now to the next 15 or 16 years, we began to realize that it's really not what we see that's important. In other words, it's really not the bleeding that we see, it's what we can't see. In other words, we can't see what's entering the bloodstream.
Right.
By looking at someone's mouth and saying, well, yes, you've got bleeding gums, you've got gingivitis, or you've got periodontitis, or whatever, that's not the relationship. The relationship is the specificity of what's entering the bloodstream. And so the real problem that we had when I say we, the real problem the researchers had is differentiating between healthy bacteria and true pathogens. The mouth itself contains hundreds of billions of different forms of microorganisms. Next to the gut is the most prolific abundance of microorganisms. So the gut and the mouth have, many. In fact, the mouth now we know has over 1,000 different types of microorganisms, and as I said, tens of billions of different ones. But they are there for a purpose, and the purpose originally is to keep infection from occurring in the mouth, but also mixed with saliva begin the digestion process. And so they work in a symbiotic relationship, just as the gut does, to help us digest our food and live a healthy life. But what we begin to realize based on our microbiologist colleagues is that there are a few microorganisms in the mouth that can become very pathogenic. And these are the ones that we began to really focus on. We learned that they have virulent properties that the health-associated microorganisms do not have. And when we talk about virulence, of course, we're talking about pathogenicity. Pathos meaning disease or pain, and genesis meaning the beginning of. So we have certain microorganisms, as we all know, on our skin and in our digestive tract that have the potential to cause disease. So it's really DNA. When DNA, and particularly PCR, polymerase chain reaction, was developed, that gave us the ability to actually look at genetic sequences that could define the difference between organisms. We know that from humans, that we all are very similar, but at the same time, there are differences based on genetic variations. The same thing is true with bacteria. There are bacteria that are very healthy. We know their genomic sequences, and there are bacteria that are very pathogenic, and we know that. So when we began to tie the two ends together, and that is the specificity of the microorganisms that individuals have relative to systemic inflammation, what we realized, as many researchers have discovered, is that if people are infected in their mouth with the specificity of these microorganisms, and they are going through the circulatory system because of bleeding tissues in the mouth, that they can actually invade cells such as endothelial cells. Of course, that's the lining, as you know, of our circulatory system. They can evade our immunological response. In other words, they have the ability to hide, if you would, inside cells such as endothelial cells, or such as such as cells that happen to be in the colon area, as an relative to colorectal cancer, as an example. And so what we're beginning to realize, and we're understanding, is that when these microorganisms invade any cell, then they change the normal DNA function of that cell. So the function of an endothelial cell is designed to line the cardiovascular system and allow blood flow to occur and so forth. But what we realized is that when they invade, as an example for cardiovascular disease, when they invade endothelial cells, that changes the dynamic of the immune response inside that circulatory system. So the circulatory systems begins to recognize something's happening there. And so the monocytes that are flowing through there normally then actually begin to go through the lining of the endothelial cells in order to try to capture these pathogens, just as they do lipoproteins. So the same principle involved of lipoprotein being involved in the intermediate space, microorganisms do that as well. And in that process of allowing microorganisms to enter the intermediate space, monocytes then follow to capture an attempt to kill these pathogens. And in the process, then they create the foam cells. And the more foam cell formation you have, guess what happens when these macrophages die? Of course, they release all of their inflammatory mediators. And in that process, the larger the foam cell process occurs, the more inflammation that occurs in the intermediate space. And thus we have the ballooning of the intermediate space into the wall of the artery, and ultimately with the potential for rupture. And when the rupture occurs, of course, then we get platelet aggregation, and then we get the blockage of the vessel. So it's not the, let's say we typically think of the cholesterol buildup in the vessel itself. Certainly that's very, very important there, but it's the inflammation along with the cholesterol buildup that allows for the rupture of the vessel. And the point I'm just simply making here relative to that description is that when you have pathogens in your mouth that are circulating throughout the body, then they can create inside the intermediate space, working in context with the lipoproteins to create a very high inflammatory area. And thus you can have potential for heart attack or stroke.
Wow. So really, in a sense, these bacteria are the first phase to create the inflammation, which then captures or would trap the LDL or the lipoproteins. So without that inflammation there, pretty good chance the LDL probably just keep floating on by.
That's right. That's really an interesting discussion here because, you know, you and I have talked a lot about what each of us do relative to our own health, and we have the same physician that we work with and so forth.
Yeah.
And as I've mentioned to you, I've been on this model now for about 11 years. And as you are aware, it's really what we can measure that makes the difference between prevention and then waiting for disease. So if we can measure, and let me kind of back up here just a little bit. I'm thinking of a paper that I read in 2012 relative, and it was called Future of Medicine. And you've heard me say this too. And the individual that wrote this said, the future of medicine involves the 4 Ps. And you may remember our conversation that, and the 4 Ps are, can we predict it? Can we prevent it? Can we personalize it? And can it become participatory, meaning can we get the patient involved? And so that's really the model that you are using in your own life and in your people that you are helping to advise. And that's the model that I've been using. And what you and I have learned in this process is that if we have the right information that is measurable, we can prevent almost any disease. Certainly there are genetic diseases that people are born with that's unfortunate that we can't prevent. But those diseases that are, let's say, multibacterial, such as periodontal disease, we can totally prevent. We can predict it, we can prevent it, we can personalize it, and we can get the patient involved. And that was what I really wanted to do with, and that's what you're doing in your life relative to preventing heart disease and stroke and diabetes and so forth. But what has been missing in many people's plan is the role of the mouth, because we didn't know how to measure that.
Right.
We can measure endothelial function, we can measure inflammation, we can measure what we call CINT, meaning the thickness of the atherosclerotic plaque inside the intermediate space. We can measure all of that, and then we can predict who might have a heart attack or stroke. But we haven't been able, until we built our lab in 2008, we haven't been able to add to the way that we measure the role that the mouth plays in the potential risk that it may have in cardiovascular disease. And the mouth is not the only, obviously, I'm not saying this to say the mouth is the only contributor, obviously, to systemic inflammation, but it is a major contributor to systemic inflammation. And the only way that we can really measure the potential that it has is to look at the organisms that cause it. And if we look at the organisms that cause it and we eliminate those organisms, or we, let's say, reduce them to host acceptable levels, it doesn't mean that we have to eradicate. We're not trying to sterilize the mouth. We're trying to create a symbiotic relationship when we have a dysbiosis. The dysbiosis is when we have high numbers of pathogens that dominate the function of the normal function of the oral flora. And it doesn't take very many of these organisms to actually dominate, because they have the ability to what we call gene transfer. These organisms are so powerful, they can transfer their ability to create disease to health-associated microorganisms, which is really seems bizarre, but they can. And we've seen studies looking at the total number of bacteria in the mouth. You know, if we put that to a 10 to the nth power, and we take one particular organism, and I'll just name it, called Porphyromonas gingivalis, or PG abbreviated, and we add 0.01% of P. gingivalis to these billions of microorganisms that occur in the mouth, the total function of the organisms in the mouth become pathogenic.
Wow. So really tiny amounts of of change could throw off the whole system.
That's correct. Blows up the whole system.
Okay. And I mean, several of my listeners, and I know most people here think of dysbiosis, and they think of bacterial fluctuations and balance and populations. They think of the gut.
Yes, absolutely.
You know, that's the common one. It's the big term now is healing the gut and all and that's certainly a source of bacteria. But you said this is a major source. I mean, is there what degree, do you know a percentage of typically of what comes from the mouth versus?
You and I talked about this a few months ago, and I'm sorry I don't know the exact number.
Okay.
But a paper that was just written this year looked at the potential of the numbers of microorganisms that actually enter the bloodstream. And traditionally, we've thought it has been the gut microorganism when it is not functioning properly, that we would tend to think, and we can find many types of, let's say, intestinal bacteria inside the circulatory system when there is a dysbiosis and when there's bleeding and so forth. But what this particular study clearly showed that the predominant number of bacteria that occur in the circulatory system are from the mouth, not from the gut.
Wow.
Which is really a revolutionary change relative to how we understand the dissemination of potential pathogens throughout the circulatory system. So when you think about that, then you begin to think about, well, gosh, the circulatory system extends everywhere. So now we have research, obviously, and we have, let's say, research scientists that are promoting that we test for these organisms. Why? Because let's take dementia, or let's take Alzheimer's disease. We now know that these and let's say spirochetes. When we think of spirochetes, most of us that took microbiology might think of Treponema pallidum and syphilis. Well, we have all learned for almost a century that syphilis can be a deadly disease because of its effect on the brain. It ends up infecting the brain in the tertiary stage. But when you look at a Treponema denicola, which is also a spirochete, you won't be able to differentiate it from a Treponema pallidum if you looked at it under a microscope. They are what I call them cousins. And so you don't really want these types of microorganisms circulating through your system, particularly lodging in the brain. So when you look at the literature relative to, the plaque buildup up in the brain itself, or in the individual with dementia, individual with Alzheimer's disease, a lot of research is showing that microorganisms in the mouth are also found in these lesions in the brain, as well as in lesions in the heart, as well as in lesions other areas of the body. And I mentioned colorectal cancer. We're finding that high numbers of, let's say, Fusobacterium nucleatum, which is one of the other pathogens that we test for, are found in colorectal cancers. And now we're looking at the mechanism where Fusobacterium nucleatum actually also invades the normal cellular structure in the colorectal region, and it actually then dominates the DNA performance of that particular cell. So rather than being a protective cell, then it becomes a hyperactive cell and one that produces a tumor. So I'm kind of going all over the map here, but I guess the point I'm saying is that we have the ability today, because of our laboratory, which I'm no longer a part of, so this is not a sales speech. We were very fortunate in that Quest Diagnostics saw what we were doing, and in 2009, Quest purchased our laboratory, and I had the privilege to work as the chief dental officer at Quest Diagnostics for 3 years, which was really an honor.
Wow, that's amazing.
Yeah, so having said that, we introduced salivary testing for oral pathogens to the mainstream.
Yeah, yes, you did. Yes, you did. And it's still, I think what's sad is that most of the public still doesn't realize the correlation. They're still looking at their egg yolks and thinking that's a heart disease risk, or their steak, which is a heart disease risk. And really, there's much more of a driver of heart disease residing in microscopic bacteria in their mouth that is going untreated, unaddressed, and they're unaware of it.
That's right. That's exactly right. And I appreciate you saying that. And I've been teaching this now for about 20 years. And what we are finding finally is that there are those out there who are going beyond the traditional training and understand the significance of this. And we now have groups around the country where dentists and physicians and nurse practitioners and hygienists and all of us are meeting together to try to learn from each other. And that is, as an example, I didn't know that, let's say 11 years ago, that I could predict whether I was going to have a heart attack or not. I didn't know how to measure that. I didn't know how to measure inflammation. Of course, I knew a little bit about CRP, but there's a heck of a lot more about it when you look at the vascular system than just HSCRP. And so the point I say is that I think that not only do our fields need to adopt the collaboration between all healthcare providers and learn from each other, which we should be doing, and we should be meeting together from time to time so that we can learn areas that we didn't know about. And then we can look at the literature and can say, is this relevant or not? And so we can provide all kinds of literature for those who, would be interested in looking at this. But what I would say to every clinician is that, consider the mouth as a part of what you are looking at relative to what you are trying to achieve, regardless of, what your particular specialty is, but especially if you're looking at inflammatory diseases. So if you're looking at cardiovascular disease, if you're looking at, let's say, diabetes, if you're looking at arthritis, if you're looking at dementia and so forth, find a dentist that is testing. Now, not every dentist is taught how to use these tests. Our schools tend to be about 25 years behind when it comes to this kind of biology and technology. And so, unfortunately, that's the case. And so the reason I continue to teach this is that it's so important to, let's say, predict and prevent. And for those that have, let's say, cardiovascular disease, or those that have periodontal disease, let's say, wherever the clinician finds a risk or finds a disease, then let's connect with someone else that can help us control that disease or eliminate the disease. A weird thing too that I didn't recognize is that I have atherosclerotic vascular disease. 11 years ago, I did not know that I have atherosclerotic vascular disease. Not only did I not know that, but I also did not know that you can reverse it. You can eliminate atherosclerosis. Did you know that?
I did know that, but
Yes.
through diet and lifestyle, you can reverse it.
Absolutely.
With significant changes to your lifestyle, but not related to bacteria. I had no idea until I was talking to you.
Yeah. So, if you find, and, you and I've talked about CINT scans, carotid, Intima-Media, thickness scans relative to the predictive value of determining whether you're going to have a heart attack or a stroke. Doesn't mean 100% that you can have a heart attack or stroke, but if the predictive value is relatively high, you better do something about it. But the predictive value of CIMT, as an example, the thickness of the wall in your carotid, can help determine whether you're going to have a heart attack or stroke. Well, if you eliminate diet, if you eliminate exercise, if you eliminate smoking, if you eliminate all the traditional risk factors that you are talking about there, but you have periodontal disease, your carotid intimate thickness will grow by itself. You hear what I'm saying?
I do, but no one else has heard that.
That's right. That's right. You can have a heart attack or stroke and be fit.
Yeah.
You know that anyway. But the point I make is these clinical trials relative to cardiovascular disease today, relative to stroke, are now looking at these pathogens and have looked at these pathogens now for the past 15 years. And they have taken away all the traditional risk factors and say, if we eliminate all these risk factors and have patients that come in here that don't have diabetes, they don't smoke, their blood pressure is normal, they're not on medication. You see what I'm saying?
I do.
But they have periodontal disease. Is it possible? But they have these microorganisms. Is it possible that they are increased risk for heart attack or stroke? And the answer is yes.
And yet, I would say the majority of MDs don't realize this.
No. Now, it's getting better. It's getting a lot better. And I can tell you many stories of patients. Can I tell you a quick story?
Absolutely. Please do.
Well, back in the 50s, what really was and I wasn't practicing in the 50s. I'm not that old.
I know you are. Wait, let me brag on you for just a second. You are 74, is that right?
I'm sorry?
How old are you? 72?
78.
78.
Yes.
78. So if you saw, and I had the pleasure of working with Tom as my client, as his personal trainer for a number of months, and he came to me solid. Like he walks like an athlete. He had veins coming out of his forearms, and there's nothing. He looks solid, and he's strong. And he came to me just to put on some muscle. We're working with diet and just to make a few changes. But the man decided to get himself in shape in his 70s, and I remember you told me the story how you wanted to get your pull-ups stronger. So you did pull-ups and you kept practicing pull-ups. You do 10 at a time, rest a minute or two, until you got to 109 pull-ups at one particular session. I mean, just very determined, very disciplined, takes care of himself extremely well with nutrition and exercise. It is not the typical 78-year-old. He's more fit than your average 40-year-old these days. So I just want brag on him. He's not discounting diet, nutrition, or total lifestyle approach. What you're saying is we're missing something. We're missing an ultimate point that can evade us, even though we think we're doing everything correct.
That's exactly right. Now, well, I'm a little embarrassed that you would bring all that up, but I appreciate that very much. We all set goals, and one thing that occurs, even though I'm not involved with the lab, I still read and I'm still asked to consult. In fact, now I'm a consultant with a new laboratory and helping them bring up some new testing and potential some point of care devices being approved by the FDA. So I'm still having a lot of fun, but in the process there, I realized that in order to have a lot of fun, you really have to be fit. And so you have to be able to move and you have to be able to enjoy life. And I do all of that. But I would say that your goals change too. When you retire from, let's say, very active practice, and then you build a lab and you retire from that, one of the problems that older people have after they retire is that of setting goals. And that if we're not very, very careful, we'll stop setting goals. And I think setting goals is really one of the most important things that we do in our life. And as a retired person, we have more time. And so why not set a goal? I want to look fit. I want to be fit. I want to be very active. And so, as you indicated there, one of my goals is to stay very active and be fit in that process. And you have taught me a lot too, along with Aaron, in fasting as an example. One of the problems that I was having with my workout model, as you were saying there, is that in looking at my body composition, that I was gaining weight because of my caloric intake. And I think I mentioned this to you also. In following some of the programs, you know, that you see on YouTube, I was eating and drinking a lot of good stuff. But having said that, and you know, using the every 3-month measurement, and you know, measure blood, whatever metabolic, and the urine, you know, measure inflammation, measure my body composition, all of that every 3 months, because I want to know where I am. And so about a year ago, just before I came to you, I had I'm 5'10", and I got to 187 pounds. And I thought, well, gosh, this is great. I've never weighed this much before. I feel strong and so forth. And then I had my blood work done. And guess what was happening?
Yeah, a little high blood sugar.
Yeah, with all of the good food and nutrients that I was consuming, not just protein, but a lot of what we would call good carbohydrates, you know, fruits, things like that. My glucose had gone, I was now pre-diabetic. And so I said, wait a minute, something's not working here. So I came to you, and then of course, Aaron, and then we started the fasting. And so the morning fasting, within 3 months, I lost 15 pounds, but I kept my muscle mass. And so I know as you teach all of this, and I know you practice that in your own life. And I would say to those that are listening there, if you're not doing that, you know, follow the diet plan that Zane is recommending here, and follow the fasting plan here. Not only will you lose weight fast, but you won't lose muscle.
Yeah, that's true. That's true. Thank you. I appreciate that. That. And I interrupted your story. I apologize.
Yeah. What was my story?
It was someone said started in the 1950s. We're talking about, I think it was related to.
Oh, yeah. Okay, great. Thank you. Well, the first real paper came out, and it was published in an oral surgery journal, about the dissemination of bacteria throughout the circulatory system. And back then, we were using anaerobic cultivation, and so they were culturing blood to see what types of organisms were occurring in the bloodstream, and they realized that a lot of these organisms, even back then, were coming from the mouth. So we were learning then, one of the first things that can occur as a result of microorganisms from the mouth and bloodstream is that you can have heart valve infections. And so the bacteria from the mouth can actually organize and grow on the valves inside the heart. And we were calling it, back when I was in school, subacute bacterial endocarditis. So that can be a deadly disorder of the heart. And so when I went through my training in the 50s, which is 10 years after that, we were being taught that, you know, watch people that have had certain types of infections in their childhood, because if their heart is damaged as a result of, let's say, rheumatic fever, then these bacteria can congregate and create an infection on the heart valve, which can be deadly. And so we were learning even back then that there were disorders that could occur as relative to infections of the heart that came from the mouth. We were also learning back then of what we call cavernous sinus thrombosis. That's when bacteria from the mouth get inside to a very small space called the cavernous sinus inside the brain. It's inside the cranium itself, and it's a very, very small area. It's very difficult for the immune system to actually create a massive immune response. And we had a nurse colleague that died of cavernous sinus thrombosis while I was in school after extraction of a tooth. She died within 3 days. And the reason she died is that we know today is these types of bacteria that we made reference to then had a massive opportunity to enter her bloodstream. It was a maxillary tooth. The brain is only about 3 to 4 inches from this area here. So she immediately had an infusion of specific bacteria into her brain, and she died. And cavernous sinus thrombosis, even today, that it can be treated with antibiotics, is still the death rate of that is still very high, something like 60%. So
Mm.
we have known for 50, 60, 70 years that they can be deadly diseases, although they are quite rare. And we do have antibiotics today that can happen. But the example I want to give to you is my son tests all his patients, and he grew up looking at a microscope with me and using DNA testing. And he had a twin, an identical twin in his office who came in. And the story was my identical twin sister, who lives in another sister, who's 32 years old, has had her second open heart surgery.
Mm.
She almost died because of an infection in her heart, and her surgeon said it came from her mouth. And I make reference to this to say, yes, our surgeon friends are recognizing the mouth is important. Our internist friends are recognizing this. The problem that in recognizing that and then doing something differently is the most difficult part, because if you don't know, if you just say, well, there's a correlation, go to your dentist. So what is it your dentist or your dental hygienist is going to do differently? So what they need to do differently is become involved in using saliva as a test, because not only can we look at these pathogens that cause systemic inflammation that may affect the heart or the brain, may affect the colorectal area, may affect the pancreas, wherever it lands. We also use saliva in our laboratory. We were the first to create an HPV test for oral cancer. And so not only are we learning that the transfer of HPV from urogenital area occurs in the mouth as well, and so that the predominant type of oral cancer that occurs today is the human papillomavirus. It has surpassed abuse of alcohol, and it has surpassed smoking as the #1 cause of oropharyngeal cancer. And
Wow.
so dentists now have the ability, through our test that we developed, to look at the various forms of human papillomavirus, in particularly the oncogenic forms of the HPV virus. So again, if you don't know that it's there, and I guess the question is, do we really want to know? Do we want to know if we're at risk for heart attack? Do we want to know if we're at risk for, let's say, oropharyngeal cancer? Do we want to know if we're at risk? I think most of us do want to know that, if there's something we can do about it.
Right.
And so I would kind of conclude all of this, that I'm saying here, is that if you are a patient, find a dentist that is using testing. There are dentists in the community that are doing that, using saliva. Find a physician. We know a good one, don't we?
Yes, we do.
Yeah, that can help you along the way in creating a plan for you to prevent all of these maladies that we hopefully can prevent, and also have them work together. And so this is what the most exciting thing has happened in my life, is that we have organizations now, and we have communities where physicians and dentists are actually collaborating.
That's amazing. That's awesome.
Yeah. And so I have a whole list of colleagues now that are testing their patients for all of the things we made reference to. And then they have a dentist that's doing the DNA test through the saliva, and then they're sharing that information, and it becomes a permanent part of their health record.
That's amazing. Yeah. For so long, medical providers have been operating in silos.
Yes.
And they didn't talk. They just like, I do heart disease. I do primary care. I do cancer. And there was no interaction. There was no discussion. And certainly with dentistry, I'm sure that wasn't even for a long time, even part of the picture, or considered who they would send someone to as a reference. How many people have their primary care provider send them to a dentist for testing and for eradication of these of a bacteria that could be the primary driver of heart disease and oral cancer. So that's revolutionary. That part is already changing. Trying to bring some holistic approach to some degree into medicine, into prevention. And so often, medicine gets caught up in treating acute disease, but unless you're like ready to go on the table.
Yep.
There's no prevention involved. It's just, can we treat acute disease? No, you're good. Okay, next.
Yes.
And prevention's not a discussion.
It isn't. Another, following that train of thought, another thing that is so exciting for me is how this whole model has changed the perception of, let's say, the oral health care team. And what do I mean by that? I didn't go to dental school because I wanted to save lives.
Right.
I went to dental school as a preference. I decided that's really what I wanted to do rather than medical school. But I didn't think that what I was going to do was going to save lives. You hear what I'm saying when I say that? Yeah. But what we are hearing today from the literature and also from those that are collaborating here is that infections of the mouth can potentially lead to early death. And so what we are finding more and more in the literature, and that we are actually advocating more and more, is that oral health means a lot more than what we've traditionally thought it meant. And that it should be as important as far as measuring is concerned. You should know as much about the measurement of your mouth relative to your systemic health as you would from the blood serum that you give, or from the urine that you give. You hear what I'm saying?
I do.
Because you can change all of that.
Right.
Yeah. And I do that. I'm a dentist. And so I have all of the other stuff that we talked about there, from scans, to everything. But I also have my mouth tested twice a year. I'm not immune from the environment, and things that I come in contact with. The mouth is an open environment. And in our lifetime, our mouth has become in contact with a lot of different people.
Right. Well, and the bacteria just on food. I mean, just
and food. Yes.
Food, air.
Absolutely.
Scratch your face.
That's it. You're gardening, and
right.
You've got some dirt on your fingers and so forth. So our mouth comes in contact with a lot of stuff.
Yeah.
And so we need to know that it's healthy, and we can do that.
Wow, that's amazing. I mean, I think you told me about a dentist here in the Nashville area somewhere that is guaranteed. He's marketing to heart patients. People have already had one heart attack. He's saying, come to me and we'll keep you from having a second heart attack. They almost guarantee, and it's not just so through the dental testing and the prevention and the treatment, as well as combining a holistic program of diet and exercise to prevent heart.
Let me kind of refine it just a little bit.
Okay.
And that is my physician colleague and nurse practitioner colleague that I started my model with in 2010 guarantee that their patients will never have a heart attack or stroke.
Okay.
But what they also say is we have to have the information from the dentist in order to make that guarantee.
I see. So they incorporate a dentist into that treatment.
Absolutely right. It's
gotcha.
just what you said. And that is, okay, we can control the lipids, we can control the blood sugar, we can control blood pressure, we can control exercise, we can control diet if the patients are participatory in the model. But we can't control the mouth because that's not our area. And so we have to have a dentist or a dental hygienist, or we have that dental team in order to help provide that information for us. And by the way, let's say we're talking about this physician or nurse practitioner model, we don't treat periodontal disease. We don't treat abscess teeth, but the dentist does. And those individuals are the ones that we're going to rely on to make sure. Let me kind of just put it this way. The goals of treating infections of the mouth now include not only making sure that there's no bleeding, so that would be one goal. Another goal is to stabilize the oral flora. In other words, to create a dysbiotic flora, or to recreate from a dysbiotic flora to a harmonious flora or a symbiotic flora there. But then thirdly, and this is the real challenge of this whole thing we're talking about, is to make sure that the mouth is not a source for systemic inflammation.
Mm.
So that's the role of the dentist. That's the role of the dental hygienist. And in order to understand that, number one, you do have to have a little more education. You have to go to some courses and kind of understand all that. And actually, we can prove that that is actually measurable. You and I talked about, I think I sent you a cutaway from the Cleveland Heart Lab of a certain, do you remember me sending you to that cutaway of the Cleveland Heart Lab artery that showed the various inflammatory
Yes,
that, you know, which is incredibly helpful for me as a clinician, but also for our patients to understand that there are a lot of things we have to measure relative to systemic inflammation. HSCRP is one, F2 isoprostaine is another that can determine how fast our vessels are aging or rusting, so to speak.
Oxidizing. Yep.
Yeah, microbial creatinine, you know, ratio, all of that's important. Fibrinogen is important. Myeloperoxidase is important. F2-PLA2 is important. All of those are relative to, let's say, generalized inflammation or relative to specific inflammation as it relates to the endothelial wall itself or the intermediate space. And when you start talking about myeloperoxidase and what we call the plaque 2 test, that's the LP-PLA2 test, then you're really talking, and if those are elevated, then your risk is extremely elevated relative to your potential of having a heart attack and stroke. But as we said early in this discussion there, all of those things are reversible. And so the reason that these colleagues say that you will not have a heart attack or stroke if you, as long as you're under my care, is if the patient will follow the model, very similar to what you are doing, very similar to, you know, what Aaron is doing there too, then me as a patient, which I am, I sleep well at night. I know I'm not going to have a attack. I know I'm not going to have a stroke. I know I'm not going to have type 2 diabetes.
Wow. That's amazing. You do, yeah, you would sleep a lot better knowing that, and addressing still really root cause health.
Perfect. I love that term, root cause. And that's what we're really talking about, isn't it?
Yes. It's exactly what we're talking about. Root cause. I mean, that's the beginning of inflammation. Inflammation is root cause. What causes the inflammation? Well, we can name a few things: high insulin, high blood sugar, stress.
Yes.
But there's a bacterial component where, as we've been talking about the whole time, we're not addressing on a large level. Like in pockets, it's being addressed.
Yes.
But again, most of the public has no idea.
That's exactly right. They don't. And unfortunately, most dentists and dental hygienists and physicians and nurse practitioners don't either. And therefore, that's the reason that I continue to kind of move around the country from time to time to help advocate that without appearing, I don't know who's trying to call me, I need to try that out, sorry. Without, let's say, appearing braggadocious here, we you know, look at certain institutions that we kind of marvel at and say, well, gosh, they tend to be a leader and so forth. And certainly Harvard is one of them. And when we developed the laboratory in 2008, excuse me, I don't know who that was. In 2008, I was invited to Harvard to speak to the dean and the Cambridge Health Alliance in order to present what we were doing relative to oral health. As a part of that, and I certainly didn't institute this whole program, but the dean of the School of Dental Medicine, who both a dentist and a physician, yes, DND and an MD degree, said, Tom, this is where oral health needs to be, and where it's going. But anyway, they started a program now, one of the first in the country, where it's called the Oral Physician Program, where dentists that really want to look more into this model of actually working closer in hand in these areas of heart attack and stroke relative to this information. They now do a rotation program and then receive an oral physician certificate. So it's good to hear, you know, that some of our schools are changing, and it's hard to change. I know that it costs money to change. It takes longer, you know, to teach people new stuff. But I appreciate you so much in wanting not only to know more about it, but also to have some kind of information that you can share.
Absolutely. I'd love to include some resources in the show notes. So anything you could tell us about where people can go to get more information about it, or would be a good
Sure.
resource.
Well, the first thing I would say is go to Oral DNA Labs. That's the one that is predominant now in the U.S. Oral, O-R-A-L, DNA, L-A-B-S.
Okay.
Their website, because on that website you will learn of all the various tests. And one is what's called my Periopath. That's the pathogen test. One is my Perio ID. In other words, we do genetic testing, or we started this. They do genetic testing for certain inflammatory markers that increase. In other words, if you have genetic variations around the interleukin family, or IL-1, IL-6, and so forth, then you are at a higher risk for more severe inflammation. And there are other tests such as the oral cancer test and so forth. But that will kind of help you understand what tests are available through saliva. I am working with another lab. We'll be bringing out another test sometime this summer. I don't want to say anything about that right now, but that's probably the first place to go. The second would be to find a dentist. If you live in the Nashville area, find one that's testing. Again, this is not self-serving, but the only one that I know that really understands this is my son, Thomas Nabors III, and he practices, and he and his whole team follow this model. And even if you just want to be tested and find out where you are, and let me just follow this by saying too, what does testing do? Well, testing provides information. Well, if we never do anything differently with that information, then the information is worthless. So the point I make with that is the traditional model for treating periodontal diseases is woefully lacking. And so that's one reason that I kind of started this whole model. If you go back to our conversation, and I know we've got time to get through. But what I would say is that if the practice is practicing what they learned in school, they're not going to cure your disease. The model has to change in order to provide the appropriate, let's say, elementary model that everybody uses, but also the appropriate antiseptics and the appropriate antibiotics if required. In order to do that, you have to understand the infection. You don't want to throw medicines at something that you don't understand, but the report will give the information, and the report will provide the information for the patient and also for the clinician. So with the goal, if it's not too severe, to cure the infection, that's what you want.
I see. Is there a network of providers that do this around the country?
There are. And the group that I'm associated with is called the AOS Group, or is AAOSH. It's called the American Association for Oral Systemic Health, AAOSH. We meet once a year, and our next meeting is this September in Atlanta. And we have all types of healthcare providers that come to this meeting to make presentations on their new findings. So, we'll have dentists, and we'll have physicians, and we'll have NPs, and we'll have DOs, and we'll have dental hygienists, and we'll have everybody coming together to say, sleep. Sleep is another real area, as you are aware of, there relative to the health conditions we're talking about. And so there'll be individuals speaking on all of that. So AAOSH is a great organization to look at as well.
For people to find a network, maybe someone in their area that would practice this.
That's a really good point. Yes, thank you. Yeah.
Okay, great. Well, thank you. I appreciate your time coming on here and just explaining this, because again, most people have no idea of the impact and the role of their oral health and these oral bacteria in the health of the rest of their body. They think it's very contained. Yes. And I think, as we've seen, it's affecting the entire body. When we know disease starts with systemic inflammation.
That's right.
Of all types.
Absolutely.
And so if you do anything to eradicate it, you're doing all the other things. You're crossing all their T's, dotting all the other I's. Got your workout routine and diet lined up, but you miss this, you could be missing the critical component in the future of your your health and your life. So thank you so much.
Can I make one comment?
Oh, absolutely.
What you said there, and then we'll finish up. And number one, thank you so much for having me. It's been a real pleasure. But secondly, an interesting scientific review brought up the question. This was in 2011, and brought up the question: is it really lipids and inflammation that we should be concerned about as the primary causes of atherosclerosis? Or is it actually preceded by the dissemination of oral microbes into the bloodstream?
That's a paper?
Yes.
I need that paper. I need a link to that paper. I'm going to include it in the show notes because that's what people are going to want to know. They got to have something to bring.
I'll see if I can find that because, I'm quoting from memory here from many presentations.
I'd love to give that to my listeners because they have something to take to their physician, take to their dentist and say, hey, read this.
That's perfect. We'll talk and I'll see you.
Thank you. Okay, I appreciate it. That'd be a tremendous resource. Well, thank you again for your time. I so appreciate it. Have a great rest of your week.
Well, thank you, Zane, and for all the help you've given me.